Dr. Lillard here. I am a forensic psychologist and associate professor at WVU in Morgantown. And I'm also the statewide forensic clinical director for forensic services with DHHR. So a bunch of different hats. Today, I'm actually going to talk to you about forensic psychology and psychiatry and kind of what it means. I don't think we've done this talk with Echo, so I'm kind of excited. I know that most people are CED here. So this is kind of more a general talk about what is forensics, what is forensic practice, what does it look like, how is it different from clinical practice, but maybe we can talk about specifically forensic practice with juveniles, because I think that's where the CED may come into play. That's where you may have some patients who find themselves in legal trouble, and we can talk about what that might look like. I can kind of tell you about the process a little bit, and we can discuss any cases that you might have, or I can pull a case out of nowhere for us if we need to. All right, let's see if I can get this slideshow working. Nope. Okay. Don't look at all of my tabs. That makes some people really uncomfortable. Okay, do we see just a PowerPoint? Are we good?
Still see like the next slide that's upcoming. Can everyone see that okay though?
Let me flip them.
There we go, perfect.
Is that better?
I see it just fine too.
Yeah.
Thank you.
Thank you.
Okay. All right, so let's talk about forensic psychology and psychiatry. So I added both psychiatry and psychology's term here because when it comes to the types of evaluations that we do with particularly criminal and civil forensic work, the work of psychology and psychiatry is very, very similar. So many of the things we talk about today can be used interchangeably when it comes to psychology and psychiatry. Okay, so Dr. Swigert, would you like to introduce yourself?
Sorry, I'm still technology. I'm Lauren Swigert, technology challenged, apparently. I'm Lauren Swigert. I'm a psychiatrist. I'm so excited to hear you talk about this, Colleen. I'm not going to waste any more time. Thank you.
Okay, so let's start with a question. What have people, and I don't know if Nick's allowed to answer because he probably knows the answer to these questions. What have you all heard about forensic psychology? Or what comes to mind when you hear the phrase forensic psychology?
The behavioral analysis unit of the FBI.
Yes, that's what people think of. So behavioral analysis unit of the FBI. Oh, let me see if I can get my slide to change.
We saw court cases in the chat.
Yes, court cases, that's another great thing. Mm-hmm.
Yep, crime shows.
Well, this is Criminal Minds, so this was a show about the behavioral analysis unit of the FBI. It does exist, it's real. The problem is that people think this is all that forensic psychology is, and really what there's 2, 4, 6 there, plus I don't remember names, Penny, Peggy, I apologize. There are about 10 jobs in the country with the FBI's BAU unit. So very hard job to get, better off just becoming an FBI agent, working your way up the field that way. Court cases, we are involved in the court, both civil, criminal, family, lots of court. What else?
We see one saying X-Files, like thinking back to that time and being a profiler.
Okay, profiling, yep, that fits kind of that behavioral analysis unit. Some people in forensics are profilers, although that's not the majority of us. Any more thoughts? Well, if you're thinking court cases, then you're probably thinking working with criminals. Let's see what else I got with my slide. Okay, So it is possible that you could do BAU work, but that's not most of us. Oh, I think we have one more chat. Yes, Stephen, yes, you are correct. Determining competency to stand trial. That is what we're going to focus on quite a bit today. So yes, that is a big part of forensic psychology and psychiatry. It's our kind of #1 type of evaluation that we do. So another example that often comes up when I'm teaching about forensic psychology is, well, is it like Swedes, Dr. Swedes on bones? And I always say this is not a good example because we don't sleep with patients. He was doing therapy with Jay-Z and sleeping with her. And the third example that people often give and question is this forensic psychology is Law and Order. And this is probably the closest example that we have of forensic work. Although, you know, when it comes to working within a police department, that's more, there's actually a specialty now of police and safety psychology, and that's kind of more their realm. But it kind of shows some of the work that forensics can do. And Elizabeth loves bones. I haven't watched it in many years. So what does it actually look like? The forensic psychology is there's kind of 2 different definitions or 2 different types of practices that fall under forensic psychology and psychiatry. But the first is a professional practice. This means like the applied practice. So not just research and teaching, but the actual clinical practice by psychologists when they are engaged as experts or represent themselves as such in an activity primarily intended to provide professional psychological expertise to the judicial system. That's a long way of saying, in general, forensic psychology is the intersection between mental health and the law. And most of the time we're talking about the applied practice of clinical evaluations or clinical treatment where it intersects between mental health and the legal system. There's also legal psychology, which tends to be more on the research side of things. So these are people who are studying legal issues and doing research about legal issues such as jury selection or jury decision making. We kind of put that more in the realm of legal psychology, less in the realm of what we call forensic psychology. And so as I'm going to talk about forensic psychology today, we're talking about a clinical practice of conducting evaluations and interfacing with the legal system. Anybody know why I have a picture of bull on here?
Because he profiles too, but like on the reverse side.
Yeah, so the show Bull was about a psychologist who helped with jury selections and he was a jury consultant. It's actually based on Dr. Phil's life before Oprah found him and made him famous. And so, yeah, what he did was, rather than kind of profile or evaluate defendants or criminals, he evaluates the jury to try to help the side he's hired by get the verdict that they're looking for. And that could be a function of forensic psychology. Kind of leads more towards that legal psychology because he's really using the research within legal issues instead. Okay. So when we're talking about forensic psychology, who are we talking about and what makes a strong forensic psychologist? So although some people will tell me that they see degree programs in forensic psychology, my advice to people is always to consider pursuing a doctoral degree in clinical psychology. In the state of West Virginia, because we license individuals at a master's level in psychology, there are a number of master's level psychologists who are conducting forensic evaluations. Outside of the state of West Virginia, that is not really the case, and you're unlikely to see a lot of them. So if a person wants to practice forensic psychology, I always advise them, you need a doctoral degree in clinical psychology. So when I say doctoral degree, I mean either a PhD or a PsyD. So Doctor of Philosophy or a Doctor of Psychology. And the reason that you're looking to pursue a degree in clinical psychology is that first and foremost, a forensic psychologist needs to be a strong clinician. They need to be strong in their assessment and interviewing skills, and they need to be strong in diagnostics. And this is where forensic psychiatry is the same. And I think forensic psychiatry really prides itself on being good diagnostically. Psychiatry in general really prides itself on being strong diagnostically. And this is a really important trait for a forensic practitioner and evaluator. Also, what makes forensic psychology a little bit different than regular clinical psychology is that a forensic psychologist needs to have really good understanding of psychology, particularly clinical psychology. So you need to know the diagnoses, how to interview people, what treatment recommendations to offer, but you also have to understand case law and statutes. You've got to understand the law. You've got to understand legal issues. You're not required to be an attorney yourself, but we do kind of understand the legal realm better than other practitioners, which is why sometimes we become the people in a place like WVU that people come to when something happens and they have to intersect with the legal system and they're super nervous and uncomfortable, like they get a subpoena to testify in court. The forensic division here at WVU often likes to talk and help consult with people about those kinds of issues. So Elizabeth wanted to know if some forensic psychologists get a law degree with an undergrad focus in psychology. So there are what's called a joint JD PhD programs where you get both your law degree and your clinical psychology doctoral degree at the same time. And so those people technically are both lawyers and psychologists. It's pretty rare. I think the people that do that tend to then go into more like policy work or really rigorous kind of academics, although they could practice forensic evaluations or they could practice law. They could go either kind of direction. I always kind of think of it as a person who wants to practice psychology, but also has a law degree. I think of it less likely to be somebody who wants to practice law and also understand psychology. Because I think you can get, you could get CEs in psychology, you could get understanding of mental health law without having to kind of get those two dual degrees. But there are certain people with dual degrees. Most of us, though, are not lawyers in any way. The other strength that forensic psychologists have and psychiatrists is to communicate, is kind of clear communication, because we've got to be the bridge between that person's presentation and more particularly that person, the mental illness that person is kind of displaying or exhibiting, and how it's going to interfere with the legal process. And so as an early trainee, many people are very intimidated about testifying in court. And while some intimidation I think is reasonable and logical, it's important to keep in mind that we know far more than any of these legal professionals do about these issues. My whole job is to understand the case law surrounding competency to stand trial, criminal responsibility, violence risk assessment. So I know all that case law and code and statute really, really well. Whereas the lawyers that I interact with, the judges I interact with, mental health is usually a very small part of their job. So they know a lot of other things in a lot of other areas. But when it comes to that small area of the legal system and mental health, we have a lot more knowledge and understanding, which is why we're there to educate the court on how best to proceed in cases with individuals with mental health problems. And this is where, the CED, you may have clients who find themselves having legal trouble. And, when there's or advocating for your client to get a forensic evaluation so that somebody can talk to the court about their mental illness and help them understand what that mental illness is, what it looks like, what functional impairments, and how it could interfere with their legal case going forward. Okay, so let's talk a little bit about the difference between clinical psychology and forensic psychology. And when we talk clinical psychology, we're talking more therapy services. So think about it more broadly than just psychology, clinical practice versus forensic practice. So here are some of the differences between the two. So the first is this, and the kind of most important is this idea of who is the client. So if you have a client with the CED, sorry, I was like trying to figure out what this says here. So with the CED, for example, if you're, who is your client when you're doing work, clinical work?
The focus person or the person that was referred, like usually the child?
Yes. So usually the child, the person who's been referred, that is your client. That is who you are supporting, you are advocating for, you are, everything that you're doing is for that individual client. And it's pretty clear, like my job is to help that client. So where it's different is that in forensics, my client is the court system. Often for court order, they're often court ordered evaluation. So my client is the judge, or my client is the attorney who has retained me. And so when I sit down to meet with the defendant or the person accused of the crime, I have to explain to them that my job isn't to help you. It's possible that my job helps you. It's possible that my report hurts you, and it's possible that it's kind of neutral and doesn't do either. But my responsibility is to answer the question that the court has asked of me. When answer that kind of psycho-legal question, or that psychological and legal question that the court has asked of me. And so then when we talk about privilege, we're talking about confidentiality. So when you're working in a hospital system, the patient in front of you, their information is kept confidential, right? Unless they tell us that they're going to hurt themselves, they're going to hurt somebody else, or there's active imminent child abuse going on, correct? And so there is a therapist-patient confidentiality privilege. This doesn't exist in a forensic evaluation. I tell the person when I sit down, I sat down with somebody at 9 o'clock this morning and I said, look, none of what we talk about is confidential. None of it's a secret. Everything you tell me, everything I learn about you, it's all going into this report. And that report is going to your attorney, who's going to decide how he wants to use that report. So the confidentiality or the privilege in forensic, either there is none, there's no confidentiality, or the confidentiality lies between the attorney and me, or the attorney and my work product, right? So if I'm hired by a defense attorney to do an evaluation and the defense attorney doesn't like my report, he can bury it. And then I have to keep confidential that I can't share anything that was in that evaluation, because it's up to that attorney to share what he wants to share, and he's decided he doesn't want to share any of them. So when we're looking at expertise of evaluators with clinical work, we need to understand the kind of the content area and also those therapeutic techniques. So with forensic work, we're understanding that contact area, but we also have to understand the legal standards, the legal statutes, the case law that surrounds it. Most of the time, clinical work is not adversarial. Right? When I'm doing therapy with a patient, I'm there to help them. I'm there to believe them. I'm there to support them. I'm there to kind of take them as they are today and help them grow in whatever way that they are seeking help with. However, in forensic work, it's often adversarial. I'm not there to help the person I'm talking to. I'm there to answer a court's question. And if the person that I'm talking to doesn't want to talk to me, I still have to answer the court's question. When you're doing clinical work, you are advocating for the patient in front of you, the client in front of you. When we're doing forensic work, we're advocating for the issues. We're advocating for the results of our evaluation and our opinions. We are not advocating for or against the person. And last, the product. The point of therapy, the product of therapy is benefits, is well-being of the patient in front of us. The product of forensic work is a report that will aid and benefit the legal system. It's not a report necessarily to aid and benefit the evaluee. So clinical work in a nutshell is all about the client. Forensic work in a nutshell is all about the legal system. So let's talk a little bit about the types, and this is just a kind of snapshot of the different types of evaluations that forensic psychologists could be asked to testify or evaluate for. Number one, the top 3 most common evaluations that we do, particularly here at WVU, is we do competency to stand trial, which we're going to talk about a little bit later. Basically, that looks at a person who is alleged to have committed a crime, has a mental illness, and they want to know right here and now, can that person go to court and work with their lawyer? We also do criminal responsibility evaluations. These are evaluations to see if somebody is not guilty by reason of insanity. So these look at a person who's alleged to have committed a crime, has a mental illness, and the court wants to know, did they understand the difference between right and wrong at the time that the crime was occurring? And then the third most common evaluation we do is violence risk assessments, or in West Virginia, we still call them dangerousness risk assessments. And so that is looking at somebody who is in the hospital under court jurisdiction, and we're trying to decide if they could go to a less restrictive environment. And so we're trying to talk about what would mitigate their risk of future violence. And along with those comes sex offender risk assessments, which has the same purpose, but is more specific and targets likelihood of sexually reoffending. One evaluation we don't do in West Virginia because we don't have the death penalty, but there are people who evaluate individuals for competency to be executed. In the United States, a person has to know why they are being executed, what they're being executed for, and why they're being executed. You have to like factually and rationally understand why the system is going to put you to death before they can put you to death. And if you can't understand that, then you cannot be executed. And that's all criminal world. In the civil forensic world, when we talk about civil, we're often talking about civil cases can either be like sometimes family court, CPS stuff falls under civil cases. Also, things such as personal injury evaluations. So this is somebody suing somebody else because they injured them. Oftentimes for mental health providers, this has to do with PTSD. So say a person was in a car accident and they're suing the trucking company and the driver who hit them. And so we are called in to assess whether or not they have PTSD from that accident and whether they should be compensated for that. Fitness for duty. This comes for law enforcement. We do fitness for duty evaluations for teachers and lawyers and doctors. It's basically, the question is, do they have a mental illness that's interfering with their ability to do their job? It's most frequently thought about with law enforcement because they carry a firearm. And so, you know, when there's excessive use of force or there's a concern about drinking, they might have a fitness for duty to see if it's safe for them to carry their weapon. Child custody evaluations, you're helping the court to understand that you have 2 parents, which parent should have custody of the child, or how much custody should each parent have. Parental fitness is slightly different. This is usually involved in child abuse and neglect cases where CPS is trying to determine if they should terminate parental rights. And so a parental fitness evaluation is, does this parent meet the low minimum standard of parenting? Can they keep their child safe from future abuse and neglect? Child abuse and neglect evaluations, disability evaluations. These are to determine if somebody can receive disability benefits. Again, this is usually for mental health concerns such as PTSD or other serious mental illness. And then capacity to testify would be if a child has to testify in a sexual abuse case because they were victimized, we can do an evaluation to see if that child understands the purpose of testimony, understands the difference between a truth and a lie. Excuse me. And if they can get up on the stand and testify. And then there's other areas where forensic psychology seems to kind of play a role. And a lot of this, I think, comes from our understanding of the legal system and of case law. We get kind of pulled into these kind of maybe gray, difficult situations or ethical issues, and we try to do some consultation. And so we may do a right to refuse treatment. So maybe this is, we do these, the psychologists do these here with the psychiatrists of decision-making assessments in the inpatient units. This may be about malpractice. So some people do a medical malpractice evaluations as well. That is a little bit about many of the types of evaluations that occur in forensic psychology. Questions on any of these? So let's take a few of those evaluation types that we talked about and put them into the context of kind of what is the time frame that we're thinking about when we're doing this evaluation, because that kind of talks about how we interview, talks about, you know, what kind of information that we're going to need, how are we going to make these opinions. So when it comes to criminal cases, we have kind of 3 different time points, right? We can be talking about the present time, past, or the future. So when it comes to criminal evaluations, the present focus here is a competency evaluation. They're alleged to have committed a crime. Do they have a mental illness? If they do, does that mental illness stop them right now? Does it stop them from being able to go forward with their legal charges, either to take a plea or to go to trial? So when it comes to present evaluations, those are kind of, I won't say they're easy, but they're the kind of easiest because, right, you're looking at functionally what is the person like that's in front of you versus having to kind of recreate something from the past or predict the future. And so those somewhat can tend to be a little bit easier of an evaluation. A little bit harder, we've got our evals that are telling us we got to go back and think about the past. So let's focus on the second one here, criminal responsibility evaluations. That's when I have to, I'm talking to a person today, but I need them to tell me what they were thinking, feeling, doing, saying, you know, 6 months, a year, 10 years ago at the time of the alleged crime. So you imagine the further away in time we get, or depending on what their mental state was then, it could be very different than their mental state as it is right now. It can be very difficult for them to accurately explain to me what their mental illness was like. Which means that for those evals, we've got to really rely on other information. Do we have records of a hospitalization, or what do the police reports say? Do they talk about anything that would suggest a mental illness? Do we have any family or other collaterals that could speak to how the person was acting about in that time? So again, a little bit harder because we're recreating the past, putting that back together. And then also we've got future evaluations. And so these violence risk assessments, I don't know about you, but I can't predict the future, right? I don't have a crystal ball. I can't tell you what's going to happen. I can't tell you what's going to happen 30 minutes from now. So the difficulty with these violence risk assessments is that initially, historically, psychologists and psychiatrists were asked to predict whether somebody would reoffend in the future. And the court found that we were no better than the average person at doing that. So we weren't awful, but there was nothing special about our skill set, which helped us to make those types of decisions. Over time, we've gotten better because we've shifted from this risk prediction to risk management. So I may not be able to predict exactly when or how a person might reoffend, but I can talk about, okay, so this is how they've offended in the past. So this is what it could look like in the future. And what if we put these levels of supervision or these things in place, would that make it less likely to occur? So we call it mitigating their risk. And so maybe if I give them, maybe if they get treatment for substance abuse, maybe if they get medication assisted treatments for substance abuse, maybe if they're involved in AA programs, maybe that would stop them from using in the future. And if they're not using, maybe they won't commit X crime. Or maybe if they stop using, they'll stay on their psychiatric medications, and because they stay on their medications, they're not likely to use. And so that's kind of the picture of what we do with violence risk assessments. All right. What time do we have here?
104.
104. Okay. A little bit of time to talk about competency evaluations. So I'm going to kind of give you the brief overview. I'm going to talk to you about the process for adults, and then I'm going to talk briefly about the process for kids for many of our CED folks here. So it's just another timeline similar to the last one. It talks about what we're doing. So person's in jail, we've got the time of their evaluation, we've got the time of trial. A competency evaluation is looking at their mental state at the time of the trial, which we assume is going to be the same as their mental state now, unless something were to change. As opposed to criminal responsibility, which is looking way back at the end, way back at the crime. So why might a competency evaluation get requested? Lots of reasons. Usually it's usually requested when a defense attorney has trouble communicating or working with their client. So this could be because of mental illness. For example, somebody may be psychotic and paranoid and unable to communicate with their attorney. Or sometimes we get the cases where people are just not willing to communicate with their attorney, and they'll request an evaluation. Maybe the person acted really strange or unusual in the courtroom. Did an evaluation one time where a guy took a pencil and stabbed himself in the arm, like 2-3 inches deep. While in the courtroom, the attorney said, yeah, I'm going to send you for a competency evaluation. It could be that the person has a history of mental illness. Maybe they've been hospitalized 5 times in the past. And so we know there's a history of mental illness. Let's see if they're currently exhibiting mental health symptoms. Or maybe something was said at the time of the crime. And so they just want to check and see if there's mental health concerns going on now. And lastly, it can be a delay tactic. Maybe the attorney is not ready to proceed with the case. If they ask for a competency evaluation, it puts a pause on everything. So you imagine you ask for the eval, it takes a month to get into the evaluator, you got 2 or 3 weeks to get the report back, then you go back to court. If they're not competent, they go to the hospital for 3 months. It can really give you another 3, 6, 9, 12 months of time before you would have to go to trial in a case. This happens less often than you would imagine. It comes up, but generally it's a history of mental illness that's going to get somebody in there. And not just a history of mental illness, but if that attorney for some reason can't work with his client, that's when they're usually going to request it. We're going to skip through all this. So long story short, the case law behind the statute for competency to stand trial is called the Dusky Standard. This came out in 1960. It was a US Supreme Court decision, which means it's kind of the law of the land. And the Supreme Court said that every defendant has a constitutional right to be competent to stand trial. It is not fair to bring charges against somebody if they can't defend themselves because they don't know what's going on. And so the kind of test for competency is whether a person has a sufficient present ability to consult with his lawyer with a reasonable degree of rational understanding, and whether he has a rational as well as factual understanding of the proceedings against him. That's a lot of words. I thought I had another slide, and I do not. So let me break that down. I break that into 3 prongs. Some people break it into 2. I break it into 3 steps. The person has to have a factual understanding of the proceedings. Well, what does that mean? That means they know who are the people in the courtroom, what are their jobs, why are they there, what side are they on? Are they there to help you? Are they there to not help you? Are they neutral? What are my plea options? What is the trial going to look like? They need to know the basics, or at least be able to be educated about the basics of the court system. That's our factual understanding. Kind of once we've established whether a person does or doesn't have factual understanding, if they do have factual understanding, then we kind of talk to them about rational understanding of the proceedings. So this is all the kind of decision making that is going to have to come into play in the courtroom. So how do you want to plead? Plead not guilty. Okay, why do you want to plead not guilty? Well, I'm not guilty because I'm an angel and God has stated that angels cannot be prosecuted for crimes. That could be an explanation given. Or it's, I'm going to plead not guilty because I don't think they have enough evidence to try me on this charge. And so we kind of go through all the types of decisions they might be asked to make in the courtroom. And the last part is, can they consult with their lawyer? And a lot of times what we're looking at here are often, we can often use the evaluation interaction as kind of a proxy for the attorney. So were they able to sit there and have a conversation with me for 2 hours? Or after 15 minutes, did they storm out in a fit of anger because they didn't like the questions they were being asked? Are they able to focus for those 2 hours, or were they kind of looking all over the room, standing up, walking around, fidgeting? And would that interfere with their ability to work with their lawyer? So those are kind of the 3 broad areas we cover when it comes to competency. All right, so let's talk about this. And then with this, we're going to talk about the juvenile system, although I don't have a slide for it, unfortunately. So up until July of 2021, so up until a few years ago, West Virginia only had a law when it came to adults who had a mental illness and were facing legal charges that they had to be competent to stand trial. In July of 2021, a new law was written that included a process for a youth who was alleged to have committed a crime to see if they were competent to stand trial on those charges. Initially, historically, the thought with juveniles was that the courts were just going to be treating them and rehabilitating them and not punishing them. And so there was this thought that, well, they don't really need to be competent because we're just going to take care of them. Well, that has changed quite a bit, and juveniles get the consequences similar to that of adults. And so if we're going to give them the consequences similar to adults, then we need to make sure that they have all the same rights as adults in other ways. So in the adult world, when somebody is alleged to have committed a crime, and their attorney maybe has trouble talking to them, the attorney will order a competency evaluation. In West Virginia, an evaluator will meet with the person, assess their competency, and make kind of one of 2 decisions. Today, are they competent or are they incompetent? If the person's competent, they stay in jail and they kind of go forward with their charges. However, if the person is incompetent, then the evaluator needs to decide, well, are they restorable or non-restorable? So this means, in the next 3 to 6 months with medication and therapy and educational services, could we help this person become competent enough that they could then stand trial on their charges? So if we think in the next 3 to 6 months they could do it, then we would opine that this person is not competent to stand trial, but restorable. However, if due to their mental illness, we think that it's very unlikely that in the next 3 to 6 months they're going to be able to understand it, then evaluator can say the person is not competent to stand trial, non-restorable. Usually, if we're at an initial evaluation and you're calling somebody non-restorable, it's because whatever the mental illness they have is, and when we're saying mental illness, we're including developmental disabilities, neurocognitive disorders. So if somebody has the advanced stages of dementia, we know that's going to progressively get worse and not better. And that if they don't understand it now and they can't retain this information now, it's unlikely they can retain that information going forward. Therefore, maybe we could say that they're not likely to be restored. Sometimes people with a significant intellectual disability will fall into this category. But I always try to educate people that just because somebody has an intellectual disability does not mean necessarily that they're incompetent. And so, I mean, you're talking about maybe a person who's nonverbal, that might be a reason for them to be not competent, non-restorable. And so if they're found incompetent, as of right now in the state of West Virginia, the person goes to Sharp Hospital. And at Sharp Hospital, they will receive competency restoration services for 3 months. At the end of the 3 months, or close to the end of the 3 months, they'll have another competency evaluation to see where they stand. And so that evaluator can say, oh, they've been restored to competency, they go back to jail and they face their charges. That evaluator could also say, okay, they're still not competent, but they've improved, and I think in the next 3 months they can get there, and we would keep them as restorable. Or they could say, look, they haven't improved at all in the last 3 months. medication has been tried, treatment has been given, education has been done, nothing is improving, this person is not going to be restored. And so this Sharp Hospital 3-month segment can go up to a year. So, and every 3 months you would get an evaluation. So we do a 3-month evaluation, a 6-month evaluation, a 9-month evaluation. Sorry, not a year, 9-month evaluation. At the 9-month point, the evaluator has to say competent or non-restorable. But if a defendant is found not competent, non-restorable, and the charge was not violent, the judge gets to decide whether or not he considers the charge violent or she considers the charge violent. But if it's considered a non-violent charge, the charge is dismissed, they go home, they're free. If they're found not competent, non-restorable, but the judge has determined the crime is violent, the court then maintains oversight over that person for the maximum amount of time they could have been sentenced for on that crime. So say it was a terroristic threat charge and the person was really paranoid and psychotic, and say medications aren't helping, they're not improving, they're called non-restorable. The court may say that's a violent charge, and maybe the sentence for terroristic threats is a 1 to 5. That means that the judge will have oversight on where they live and what's like supervision criteria they need for the next 5 years. And then we start the risk assessment process of trying to see what is the least restrictive environment that still mitigates their risk and keeps the community and this person safe. So this is kind of competency evaluation for adults in a nutshell. In the juvenile world, it's pretty similar. The interesting thing with juveniles is that if you're under the age of 14, the courts presume that you're incompetent. So any kid under the age of 14 who commits a delinquent charge, so not a status offense, which is something that they wouldn't be charged with if they were an adult. So underage drinking or truancy, none of those count. But any delinquent offense that would be a criminal charge if an adult did the same thing. If they're under the age of 14, they're automatically considered incompetent. And so if a prosecuting attorney thinks, well, no, I really think that this kid is competent, he can go forward on these charges, but he's under 14, then they get a competency evaluation to see where they stand. If the kid is above 14, we consider that they're presumed competent, and we do an evaluation to see if they have, because of a mental illness, are not competent. So above 14, they look like the adult process. Below 14, they start incompetent, and we do an evaluation to see if they actually are competent. In the juvenile system right now, there's no hospital for the juveniles to go to receive those services. The services are provided by competency attainment providers in the community. And so we have 4 different competency attainment providers in the state of, we have 4 different agencies who have competency attainment providers in the state, and they all have their own catchment area. And we have a little area of no provider at this point in time, but we're working to get that resolved. And so if a youth is found not competent to stand trial, they can receive kind of the educational services to remediate them to competency with these remediation providers in the community. So they can stay at home and receive it, or maybe they're at a shelter, they can get the services there. Sometimes they're still in detention, which we don't like to do, and they can receive the competency services in detention. And then the competency evaluation process happens every 3 months, and we determine ultimately, are they competent, go forward? Are they incompetent, unable to attain competency? If they're incompetent, unable to obtain competency, then the judge kind of gets to decide what to do. You know, he can drop the charges altogether. The judge could decide that they should just be sent to a treatment facility, and they'll place them under DHHR's custody to send them to treatment. They could request a dangerousness assessment. So there's kind of, it leaves the judge a lot more options than they have with adults. Thoughts on this process? Adults or juvenile? We have about 10 minutes. So I'm gonna stop my PowerPoint there.
We can continue on a part 2 if you'd like to, Dr. Lillard, as well. We do have some available dates if you'd want to.
Yeah, we can maybe reach out and see what other people want to hear about, maybe what specific topic.
Yeah, and we also have a poll for this after. We're going to start doing a poll second session of the end of the month, just for our statistics and such and data. Does anybody have any comments or questions?
Maybe I'll stop sharing.
I just always love hearing Dr. Lillard talk. So you can talk about anything. I can always learn about forensics and what you do. I love it. I would love to hear you take this a little bit more into sexual offending behaviors and those evaluations. Personally, I know a lot of people on PBS would probably like to hear some of the overlap of that with sexual acting out behaviors, if that's something that we could learn more about from you. But I would listen to you all day. I really appreciate this. This was
Do you
great.
want that more focusing on kids?
Oh, I think we could probably benefit from both ends of it. There's enough need out there. That's an area I think all of us could learn more about, especially how it overlaps. But I know that's been a consistent question that people often bring up is wanting to understand both the evaluation of that behavior so that you can really get a good assessment. It tends to as gets labeled and not always understand the etiology and what's clinical versus legal in its nature. But I would say for both adults and kids, although I know a lot of people are often dual providers in that area that because it's more specialized, but
Yeah,
I'd listen to you talk about anything.
we actually have been just discussing that at kind of at a state level recently. I've noticed I've received a couple of evaluations for very, very young kids, like age 10, and they want a sex offender risk assessment. And so the youth acted out sexually or engaged in sexual behavior. And what we're finding is that the prosecutors in the state are charging them with secondary sexual assault or incest. And I'm not saying that what they did is right, but what they need is treatment for sexually reactive behavior or sexual behaviors. And what they don't need is to be labeled as a juvenile sex offender for the rest of their lives. And so we're actually going to kind of do a push, an education push with prosecutors to kind of help them understand the fact that they probably could get more resources for these kids if they don't go through the prosecution for the crime and rather just kind of get them the services that they need.
Yeah, and I think on the clinical end, helping clinicians understand how to tease that out and do those assessments and understand the difference is also really important because they just see the behavior and label it based on the behavior and not the etiology. And I know you spend a lot of time teasing through that. And so that's the type of thing I think we could really benefit from if that's, I don't want to speak for the group, but I would love to hear more about that.
That's a really interesting question because I think that's hard. And the examples I have on the top of my head are ones that are to the extreme. I can't remember. One of them was, I don't know, I'm making up ages now. So a 12-year-old girl and a 17-year-old boy and their brother and sister, and they were engaging in sexual behaviors together. And they charged both of them with sexual offending. And I'm asked to see the 12-year-old for a sex offender risk assessment. And I'm saying, wait a second here. She was the victim in this case. And both of them were the victims of poor boundaries at home that did not let them understand that this sexual behavior was not okay. And my risk assessment is not helpful to you. Did you have a question, Stephen?
Yeah, you mentioned that sometimes you're asked to evaluate parents for, whether or not their rights are terminated. Is your focus in that instance, well, is it focused on that specifically, or is the effect on the child? Is that at all considered in that evaluation?
So that's a great question. So those evaluations are they're really heavily focused on the parent's ability. And so we have usually a substantiated abuse complaint, usually a litany of previous allegations of abuse. And they're trying to say, you know, does this person, well, one, does a parent have a mental illness? And is that mental illness going to interfere with their ability to continue to parent? And so with that one, we look a lot at like functional, like, oh, as I break my pen, functional abilities. Like I break it down into issues of transportation, issues of safety. Can this parent understand? Do they understand what temperature is a fever, and when should I take the kid to the doctor versus urgent care versus emergency room? Why should I have carbon monoxide detectors in the house? Like we gonna get into those like real specific kinds of questions with them. And the way that I conduct those evaluations is not to tell the courts terminate rights, don't terminate rights, but I usually say, okay, here's what this parent needs in order to keep the children safe from a future abuse and neglect. And it may be they need individual therapy, or they need parenting, or they need substance abuse treatment, or they need medications. And then I kind of let the court take it from there. But that is a whole lecture in and of itself that we could talk about if people are interested.
Yeah, please send us any topics that you're interested in for the group, and we can look over that. Thank you for that question. Anastasia?
Thank you for this presentation. It was really interesting. And I also want to second the whole idea of having like the sexually reactive behavior talk, because I think that will be really, really helpful for us. And with that, I was wondering if we could get some like list of some resources throughout the state for sort of, you know, what things to lean on and that kind of stuff. We get asked that a lot. And so
When it comes to like the forensic area.
yeah, and just like we have some guidebooks and that kind of thing about healthy relationships, and I know there's some really great books like Norvalidarian stuff, like The Rules of Sex and that kind of stuff. So we have some of those pieces, but like providers that are really specialized in sexually reactive behavior and that kind of stuff, I think we need a little bit more help on how to guide people to how to seek more outside help for that. And then I have a question too about the competency evaluators, the 4 of them throughout the state. Who are they? And like,
Oh,
I guess.
you're talking about the competency attainment providers?
Mm-hmm.
So the competency attainment providers that we have right now, Healthy Minds, formerly Summit Center, Genesis, Prestera, and Eastern Family Resource Network. Those are the 4 agencies. We're trying to find one to cover kind of the southern eastern chunk of the state, although Genesis is willing to help us if there are kids in that region that need services. And we will have a flyer that's still going through communications, but once it's out, I'll make sure I get it to Elizabeth to share with you all in case that comes up.
Awesome.
Is that under like the Safe at Home?
No, it's totally separate. It's kind of like a multidisciplinary, multi-bureau effort within DHHR.
How does Safe at Home figure into all of this?
So that's a great question. I don't know as much about Safe at Home. My thought is that if Safe at Home was being utilized like it could be, then it would stop all that other stuff from occurring. That would kind of be the step. This would be once there's like legal charges and things have kind of progressed further than Safe at Home, which is part of the problem right now, is that once the kid is to the point where they get a competency evaluation, it's usually because their behavior is such that they're not safe to be in the home.
But there's nowhere else to put them.
Right. So unfortunately, they sit in shelters or detention centers.
That's not cool.
Yeah. So what the state could really benefit from beefing up, well, either get a new program or beef up, is right now the state has funded functional family therapy, or they used to, and NIAP, I think, is the only provider of functional family therapy. And I think there's there's not very many providers, but functional family therapy or a similar program, multi-systemic therapy or MST, is, the research has said, is very good at helping keep kids in the home, but it works with these kind of conduct disordered behaviors. And so that's my push, is that I think if we want to keep kids in the home that are at this point, we need stronger in-home interventions. The safe at home, well, I don't know much about safe at home, the model itself, but I'm not sure safe at home alone gets them the intensive mental health treatment that they need. I think it's got to be safe at home plus other services that are really hard. But again, maybe this with a CSED waiver or something that would be more feasible.
Great questions. Thank you so much, and great discussion. So we're just going to go ahead, just in the interest of time. I'd love to have a longer session. This is really great. Dr. Lillard, I'll get her slides out and then we'll figure out a part 2 and other topics that you guys had discussed. I'm going to go ahead and put up that poll for everybody, if you don't mind taking a moment.